presenters. Thank you. We are glad to have these two presenters taking us through what have we done as a country, how far have we come, what have we learned, and what are some of the challenges we've experienced in trying to improve the safety of care and improve the quality of care across the country. So Dr. Irungu will be speaking from a national level, and Boniface will be giving us the county perspective. And I look forward to all of us contributing in this conversation in the chat box, in the Q&A section, asking our questions, giving our contribution, and contributing to this conversation. How do we start for those facilities that we feel have not started? How do we grow for the facilities that have started and want to scale up? And how do we also mentor each other and learn from each other in this journey? Our partners in this session, we have the Ministry of Health, which is leading us. We have World Health Organization, we have CDC, we have Society for Quality Healthcare Kenya, we have Moi Teaching and Referral Hospital represented, the County Government of Nyeri, which is represented here. We have Aga Khan Health Services, COFPAC, which is the Co-Fraternity of Patients Association in Kenya, the Nairobi Hospital in Perspective, and we also have representation from Laikipia County. Thank you very much for joining us, and many other partners that I've not mentioned. Thank you very much for joining us. Dr. Irungu, would you like to start off this webinar?
Yeah, thank you. Thank you so much, Dr. Kalondo. So allow me to start by sharing. Maybe you can just confirm that my screen is visible.
Yes, it is very visible. Thank you.
Yeah, thank you so much. And welcome all of us who've been able to join in this early series of webinars on patient safety. My name is Dr. Irungu Kamau, heading the Patient Safety Unit at the Ministry of Health. And so, in the interest of time, I'll proceed with this presentation, in which I want to basically share a few basics around patient safety. I'll also talk about briefly on the World Patient Safety Day, and focusing some insight on the theme for this year, which is about diagnostic safety. Then I'll give a highlight of the global patient safety initiatives, and briefly share where we are as a country at the national level in terms of patient safety. So I think we're all aware that patient safety basically focuses at preventing errors, preventing adverse effects that may occur to patients while they are receiving their care. And it emphasizes that patient safety is a key aspect of quality of care and involve all efforts that are put in place to reduce risks, reduce errors, and any harm that may occur to the patient. These are definitions by the World Health Organization, but I believe it resonates well with what you are doing. So the main focus of patient safety is to improve health systems to ensure that all practices offered are safe. It also focuses on being able to identify as well as learn from any mistakes or adverse events that may occur to patients, and also focus on promoting a culture of safety where all professionals and health systems are encouraged to improve care quality and also minimize harm. So that is basically the scope. And patient safety started early. It's not a new phenomenon. And we know, all of us in the healthcare fraternity, as early as the 19th century, we had the issue of the Hippocratic Code, which emphasized the issue of do no harm. Later, around 17th century, we had advancement in surgical techniques and sanitations, for example, the use of antiseptic practices. For the nurses, we are aware of the Florence Nightingale's contribution to hygiene and prevention of infection during the Crimean War. Then later, around 19th, 20th century, we saw the rise of modern hospitals and increased focus on more structured healthcare. We had introduction of anesthesia, aseptic techniques to reduce surgical risks, and also early medication sterilization coming later in around 1800s, which created formalized training for physicians and nurses, all aimed at improving patient safety. Then later in around 1930s, of course, antibiotics came in with the improvement in surgical techniques, reducing mortality. We had around the World War II growth in technology and specialization in healthcare. And later around 1950s, we had studies being done on medical errors. And among the first researches were done were anesthesia-related deaths. Then later in the modern day era from the 1980s to the current, we had, for example, the 1994 Harvard Medical Study, which was the first large-scale study on medical errors done in the US. Then later, around 1999, the Institute of Medicine, there was a report on to errors to human. Then early 2000, we saw the insurgence of emergence of checklists, safety protocols, and culture of safety in healthcare institutions. And then we also saw now the establishment of patient safety organizations, like the WHO Joint Commission, and others who began advocating for global patient safety standards. So following from now around 2000, I think this is where we come in. And with especially from the WHO perspective, we saw a lot of issues arising around patient safety. For example, in the 2004, we had the first global patient safety challenge, whereby the World Alliance for Patient Safety was formed to raise awareness about patient safety issues. In 2008, we had the surgical checklist, WHO surgical checklist. Then in 2017, we had the second global patient safety challenge, which was medication without harm. Then we have seen establishment of various national patient safety agencies, a lot of collaborative effort around patient safety, for example, the International Patient Safety Goals, Patient Safety Action Networks, Global Patient Safety Collaborative, so many collaborations that are focusing on improving safety. Then the issue of digital health and technology has arisen, driving a lot of patient safety innovations. Then around 2016 to present, we've been having global ministerial summits, which are trying to buy in support for patient safety from various ministers from the member states of the World Health Organization. From 2019 to present, we are aware we've been commemorating the World Patient Safety Day. And again, there has been a lot of emphasis on patient-centered care. And if you remember, our last year's patient safety theme focused more on patient-centeredness. So that's basically a small history. And under WHO, there are various priority areas which have been identified. And these have tended to form various themes from which we commemorate World Patient Safety Day. We know that among the highest concerns include medication errors, issues of surgical errors. We've seen about the issue of the surgical checklist. Number 3 comes issues around healthcare-associated infections and associated impact of antimicrobial resistance, issues of sepsis, diagnostic errors, which is forming the theme for this year. Then there are then others like falls, ulcers, and so many other concerns. So specifically on the World Patient Safety Day, as we see, it has been commemorated all the way back from 2019. It's an annual event which is observed on the 17th of September to raise awareness on patient safety and promote actions that may help reduce harm. And basically the objective is to emphasize the importance of patient safety and promote efforts that can be used to mitigate these errors. So we've had various themes. From 2019 was a global health priority, patient safety, a global health priority. 2020 focus on health worker safety. 2021 focus on safe maternal and newborn care. 2022 on medication safety. Last year, the focus was on engaging patients. And this year, the theme is on improving diagnosis for patient safety with the slogan, get it right and make it safe. So There are usually various key activities which we, at this point, we would wish to encourage even participants here within their own counties to participate. We have conferences that range from global conferences to national conferences. We have a lot of educational campaigns to create awareness. There's the landmark illumination in orange, whereby you can identify a building and illuminate it in orange. Engaging patients and health workers during your activities. Coming up with online campaigns and other social media outreach programs, as well as workshops, and also being able, if, where possible, to have awards and recognitions of individuals or entities which have done better in matters patient safety. So the theme for this year is improving diagnosis for patient safety, and the focus is on addressing diagnostic errors, which may range from delayed, incorrect, or misdiagnosis, which are key contributors to preventable patient harm. It also aims to highlight the importance of accurate and timely diagnosis, which is a crucial aspect of the safe healthcare delivery. And the slogan, "Get it right, make it safe," basically encourages health workers to prioritize diagnostic accuracy to reduce harm and improve on outcomes. So the objectives for the 2024 World Patient Safety Day, one is to raise global awareness. I'm not going into so much detail. So we need to raise awareness both globally and regionally, as well as nationally, and also within our local settings. Encourage a multidisciplinary approach. Remember, patient safety is not a one-man show. So there are many players who might come in to promote and support patient safety, and importantly, to empower patients. Most often we forget our patients. So it's important to encourage patients to actively participate in their care, and specifically in understanding the diagnostic process for their conditions, and allowing them to ask informed questions about both the diagnosis and about the general aspects of their health. And the key activities are not repeat. The issues of campaigns, awareness creation, landmark illumination, social media campaigns, and such. So specifically on diagnostic safety, very briefly, we know a diagnosis identifies a patient health problems. And to reach a diagnosis, patient and the healthcare team must work together to be able to navigate a fairly complex process, which sometimes is prone to errors. And it should involve discussion with the patients, examinations, followed by testing and review of results. So diagnosis is not just a lab diagnosis or a biological diagnosis, it's a process. And that's one key message that we need to take in. And all the way from the point the patient comes in during your history and examination, errors can occur, and this may have fairly significant consequences. Of course, any delayed or incorrect or misdiagnosis can prolong illness and may lead to disability or even death of that patient. So for this year, there are various key messages which have been highlighted at the global level, and which we can be able to accommodate within our settings. And the first key message is that correct and timely diagnosis is the first step to preventative interventions and effective treatment. So it has been seen that diagnostic errors may account for up to 16% of harm, and they may include from misdiagnosis, incorrect diagnosis, delayed diagnosis, or even miscommunicated diagnosis. So all this can cause a lot of grave danger. And we are aware that errors can worsen patient outcomes, and correct and timely diagnosis is the foundation of effective healthcare, as it will enable healthcare providers to be able to identify the cause of the patient's symptoms and be able to institute appropriate interventions. So the second message is that understanding the diagnostic process is key to reducing errors. And we have just said that the diagnostic process will start all the way from the patient initial presentation, the point of taking history and examining the patient, the routine diagnosis that we do, be it lab-based or any other format, There's the part of discussing and communicating the results, a lot of collaboration and coordination, like between the lab and the clinician, between the radiology and the clinician, between the lab and the patient. Then they're able to come up with a final diagnosis and a treatment plan, followed by a follow-up and the evaluation. And errors can occur at any of these stages. The third message is that a range of solutions are available to address diagnostic errors, and policymakers and healthcare leaders should be able to foster positive workplace environments, should be able to provide provision of quality diagnostic tools, and health workers should be encouraged to continuously develop their skills and address sometimes the bias that may occur in terms of judgment. And most, again, very importantly, patients should be supported to be engaged through their diagnostic journey. So the last key message is that diagnosis is a team effort. So timely diagnosis require collaboration between patients, families, caregivers, health workers, health leaders, as well as policymakers, and all these stakeholders must be engaged in shaping the diagnostic process and empowered to voice their concerns if any may arise. Those are the key messages, but I believe more messages may come up. So out of that, we'll briefly talk about the global and national patient safety initiatives. Currently, we have what we call the Global Patient Safety Action Plan, where member states are advised or to be able to see what they're able to achieve. And the action plan comes in a form of a matrix of 7 strategic objectives, as well as 5 action areas per objective, bringing out a total of like 35 interventions that we may put in place to address patient safety. So sometimes when you're assessing your progress, you can look at how well have you been able to capture these 35 elements. And they range from policies that may be there to reduce patient harm, issues of systems, issues of safety of processes, clinical processes, how well we are able to engage with our patients and family, issues around education of the health worker, issues of research, as well as being able to build synergies and partnerships in the journey. So what I've circled here are areas which we feel like as a country we've been able to achieve, or rather we are attempting to achieve, and I'll highlight those, what we've been able to do. So under policies to eliminate harm, as a country, we've been able to develop a national policy and action plan that focuses on the safety of the health worker as well as the patient. And we've been annually commemorating our World Patient Safety Days. So these have been pulled together under policies. And the issue of systems, we have a patient safety unit domiciled within the Ministry of Health. And we have a structured leadership that supports patient safety. Around safety of clinical processes, we have a very robust IPC program at the national level, an AMR program again at the national level. We have a whole division that focuses on safety of medical devices, medicines, bloods, and vaccines. And we've also been able to develop guidelines on safety of clinical procedures. Beyond what we've done as IPC, other programs have also been able to come up with very clear guidelines like safe surgery, issues around maternal and child health, they have been developed. So in terms of the program, this is where the unit lies. We fall within the State Department for Public Health. And our unit runs the IPC programs, the AMR programs, as well as the patient and health worker safety program. And as you can see, all these relate to quality, and that's why the unit falls within the division of quality assurance at the Ministry of Health. Then we've been able to develop key guidelines. I've talked about our patient safety policy and action plans, and not forgetting our other key documents like our IPC policy, our IPC action plans, our AMR policy, as well as our AMR national action plan. And these are just a spotlight on our patient safety documents. Then this just highlights what we've been able to do around IPC. Remember, healthcare infection prevention for like number 3 in terms of areas of concern in terms of patient harm. So I'm not going into so much details of that. We have our IPC guidelines. We have our healthcare-related infection guidelines, as well as our policy and action plan, with very clear strategic areas ranging from leadership, advocacy and communication, health education, health worker safety, availability of IPC supplies and infrastructure, surveillance, as well as monitoring and evaluation of IPC practices. Under AMR, we have a very clear strategy with key strategic areas, 6 of them, in terms of creating governance and coordination, creating awareness and education around the AMR, AMR surveillance, rational use of antimicrobials to require antimicrobial stewardship, research and development, and of course, not forgetting the infection prevention and control. And we've seen quite a good government commitment, and these are just extracts from last year's World Patient Safety Day. And you can see on the news, like during when the PS flagged off the walk for the World Patient Safety Day 2023, it showed quite some focus, some commitment to support of patient safety efforts at the ministry level. I think here we are just seeing about another key thing where our cabinet secretary then shows commitment to ensuring patient safety, and this was in a meeting in Montreux during the ministerial summit that happened annually. So the other key areas around patient and family engagement, I think when we are developing our policy and action plan, we've had patient representation. We've experienced patient stories shared during our World Patient Safety Day, and we purpose to include patient and family representation in the National Patient Safety Committee, and we also purpose to develop key patient and family information and education and communication materials. Then around health worker education, we've already developed a patient safety training package, which is already on the MOH Virtual Academy, awaiting a rollout. And we keep advocating for a safe environment for our health workers. Around information and research, we've attempted to pilot patient safety incident reporting. The uptake has been low because we are able to come up with a system linked to the Kenya Health Information System. But I think there's still a gap in terms of the readiness of healthcare workers to report on patient safety incidents, most likely because of fear of litigation and such. But over and above the incidents, we are doing very robust surveillance of antimicrobial resistance, multi-drug resistant organisms. And we've just finalized our healthcare associated infection surveillance guidelines, and we hope to roll out surveillance of HAIs in due course. Then, in terms of synergy and partnership, as a country, we are a member of the Global Patient Safety Collaborative, which has supported quite a number of our patient safety initiatives. Recently, we had patient safety leaders, do a visit to Singapore to just benchmark and see how patient safety happens. I've talked about participation in various global patient forums, like the Global World Patient Safety Day conference we were able to attend last year. And we're also part of various regional groups, like the East African Community of Practice on AMR, IPC, all this attempting to foster patient safety. What I've put here is basically a report on the Global Patient Safety Bulletin, which has highlighted Kenya as among the countries that have really risen in trying to improve on patient safety. And they were highlighted and actually used as a case example. This is just an extract from a meeting organized by the Global Patient Collaborative, where we had leaders from various institutions representing the country. And being part of the Global Patient Collaborative, considering the number of countries that exist, Kenya, we are lucky that for the last, now I think we are going to the 8th year, we've been, because of our efforts, we've been recognized and we continue being supported to promote patient safety initiatives. Of course, all this work has not come without challenges. And I think one of the biggest challenges, of course, the issue of resources, which has affected our ability to be able to invest and maintain patient safety initiatives. We lack a good pool of trained healthcare professionals. And if they are there, sometimes we see a lot of high turnover rates in terms of commitment to work. And all this may affect patient safety. Issues of infrastructure. Sometimes poor healthcare infrastructure may impede effective implementation of patient safety initiatives. For example, you can encourage people to perform hand hygiene, but there's no water, there are no sinks. So all these sometimes really affect. Another key issue is about attitudes, cultural attitudes, norms, which may influence acceptance and effectiveness of safety initiatives. Then we also lack a good patient safety incident surveillance system, such that we may not be able to actually account for the burden. Yes, we know it's there, but remember, data informs decisions, data informs policy, so they need to come up with such a surveillance system. Again, I would say sometimes lack of governance structures or even sometimes lack of commitment from leaderships to prioritize patient safety initiatives. So you might find there are maybe other key areas that may become supported within a healthcare facility, and interventions that may promote patient safety may be forgotten. I've talked about gaps in education and training. And lastly, issues of lack of regulatory frameworks which may enforce safety standards. So these are just a few challenges. There are many, and I believe at our own spaces we can be able to list more of these. So I want to end there, and I'll be keen to respond to any questions that may come later. Thank you so much.
Thank you very much, Dr. Irungu, for that elaborate presentation, and we thank you for highlighting all the efforts. I don't know, maybe in the chat we could put how many of us were aware of these efforts that have been happening across the country. Were you aware of these efforts, or is this the first time that you are appreciating the amount of effort that have been put on at the country level? Boniface, would you like to start off your presentation?
Yes, Dr. Karundu. Good afternoon, all.
Good afternoon, Boniface.
Yes, let me start sharing my screen. So I'm Boniface Macharia, IPC, Patient Safety and Quality Improvement Coordinator at Nyeri County. And I just feel honored to be here today to discuss this critical topic that affects us all, that is patient safety. And our focus today will also be about Nyeri County Referral Hospital and the significant steps that we have taken to improve the patient safety within our facility. So patient safety is not just a policy, they say it's just a fundamental principle that underpins everything that we do in healthcare. So today I'll walk you through our journey in enhancing patient safety and outcomes we have achieved, the challenges we have faced, and the lessons we have learned along the way. Oops. Sorry, had a hand screen. So on our outline, to guide our discussion, I will first provide some background on Nyeri County, including the demographic and healthcare context. Next, I shall delve on the specific activities we have undertaken to align with the National Patient Safety, Healthcare Worker Safety, and Quality of Care Policy. I shall then review the outcomes of these activities, discuss the challenges we have encountered, and share the lessons we have learned. And I will also talk about our no-bed sharing policy and highlight our plans for upcoming World Patient Safety Day, which is next week. So on background of Nyeri County, Nyeri County is home to approximate 850,000 people, which are served by a variety of healthcare facilities, as you can see. And among these level 4 facilities, level 1, level 5 facility, and several other lower level facilities. This network provides essential healthcare services to our population, but also presents challenges in terms of coordination, resource allocation, and most of all, patient safety. So understanding this context is crucial as we consider the healthcare needs of our community and the measures we have implemented to improve patient safety and quality of care. So Nyeri County Referral Hospital is at the heart of our healthcare system in Nyeri County, and it's a vital institution serving thousands of patients each month. Our OPD alone handles about 10,000 cases every month. We have a bed capacity of about 263 beds, 53 cots, which amounts to 330. We also have specialized services, which includes oncology, renal care, and intensive care. These statistics underscore the importance of robust patient safety measures given the volume and the complexity we have to deliver as healthcare workers in Nyeri County. On priority objective number 1, which is to strengthen leadership, governance, and coordination mechanism. To ensure patient safety, we have focused strengthening on leadership, governance, and coordination, where we have the county patient safety focal person, who happens to be me. Then we have other hospital technical committees. I will name them later. And quality of healthcare services, which includes service charters, suggestion boxes, and then quality improvement committee and compliments and complaints resolution committees. Additionally, we have patient education sessions that are the cornerstone of our efforts, ensuring that the patients are well informed about our services available and to them how to navigate our health care systems safely. On a priority objective number 2 on patient safety, we have to protect the patient from avoidable harm while undergoing healthcare. And central to our patient safety strategy is protecting the patient safety, the patient from avoidable harm. And to achieve this, we have established various committees. As you can see, we have the pharmacovigilance committee, which is under the MTC. We have IPC, AMS. We also have OSH, occupational safety, which is not among these, which are on the screen, and also the quality improvement team. These bodies play a critical role in overseeing patient safety measures, conducting mortality audits, and resolving complaints, all which contribute to the safer healthcare delivery in our health facility, that is Nyeri County Referral Hospital. We have the well-being. We recognize the safety of the well-being of our healthcare workers as integral to our patient safety. And to this end, we have established a NOSH, or Occupational Safety Health Committee, that is at the county referral. We have provided fire safety training and even set up fitness center to promote healthcare worker well-being. They say a healthy, well-supported workforce is essential for maintaining high standard of patient safety. This is according to WHO on SDG 3, health and well-being. On priority objective number 4, ensuring, sorry. Occupational safety and health committees are registered with DOSH. And in fact, our facility is waived as much as we have, every facility has to pay 5,000 per month, per year. We have a fitness center, a disability mainstreaming, that is LAMPS and disability-friendly lavatories for our patients, anti-slip floor trials, hospital signages, feedback mechanisms handled by the QI committee, and also cleaning, security and the cleaning services are outsourced, are privately outsourced. And to ensure provision of quality healthcare services, our quality programs, that is the KENAS, we have accreditation of our laboratory, that is the microbiology and biochemistry lab at the County Referral Hospital. And then there is that CHMT of the County Health Management Team, supportive supervision, which is done quarterly. At the level 3 downwards, that is the community health. We have safe care, which is done digitally, self-care level 3 up to level 1. And then there is a registration of the hospital with the Kenya Medical Practitioners and Dentists Board, and there is the accreditation certificate for a laboratory. Still on priority objective number 4, there is registration of our pharmacy with the Poisons, Pharmacy and Poisons Board. Our healthcare workers are licensed with their respective regulatory boards. Pharmacovigilance, reporting of medications, transfusion errors, and poor quality medical products to the Poisons, Pharmacy and Poisons Board. We have on-job training, CMEs for our healthcare workers, hospital technical committees, as we had named them, and the mortality meetings, which are supervised or checked every quarter during the supervisions by the CHMT. Priority objective number 4, continued to ensure provision to quality healthcare services. We also have patient education sessions, which are face-to-face mostly. It's done weekly by our health promotion officers. We have health messages and information on NHIF enrollment. Now we are doing the SHA1 on TV screens in our facilities. Use of social media to relay hospital-related information. We have various hospitals, including now the Nyeri Referral Hospital, which have an active Facebook handle, our Facebook page, sorry, and also a Twitter handle. Then there is the client satisfaction survey, which is done yearly. Department service charters, community scorecards, which is done once in a year, and patient safety work plan 2024-2025, which will guide us through the year on patient safety. So the outcomes, as we shall see later on, we have reduced mortalities, reduced length of stays. We have improved patient care, which is closer monitoring of our patients, privacy, and as reported by healthcare workers, and improved environmental cleanliness. So looking at the data that we have, for instance, male medical ward, after the no sharing, we have the no bed sharing policy. Back in 2019, we had 342 mortalities. Today, in 2022, we have 159. Someone may ask why I'm using the data of 2022 rather than the 2023-2024. Last year in 2023, the male and female medical wards were closed for renovations for a long time, and the numbers that we have don't reflect the numbers that we have for our Nyeri County Referral Hospital. For this year, I don't have a complete set from January to December. Therefore, the decision made to work with the 2019 to 2022 to show the significant change. And as you can see, there is a lot of change. Then the female ward, we had 15 mortalities in 2019 versus 10 in 2022. And looking at our no bed sharing policy, in response to COVID-19, we started this, and as you can see in these pictures, you can see about three mothers sharing the same bed. That is in 2019. And after the policy, we have every other patient having his or her own bed. So in response to COVID-19, we implemented the no bed sharing policy in March 2020. And this policy was developed by the IPC committee and has been critical in preventing the spread of infections and improving patient outcomes. It is a clear example of how adapting to new challenges can lead to lasting improvement in patient care. This is evidence in our Nyeri hospitals, not only Nyeri County Referral Hospitals. So the county implemented the downward deferral mechanism to level 4 hospitals within the county. And to support the no bed sharing policy, they established downward deferral mechanism. It directs patients to level 4 hospitals within the county. And this approach has helped us manage the patient load effectively and ensuring no patient is left without appropriate care. And staff patients have been sensitized on this process. And the county government, along with the referral facilities, have provided a strong support to this policy. Then we have the ambulance command control, which further enhances our referral system. We established an ambulance command and control center along with the central admission desk. We have a referral coordinator who oversees the referrals, ensuring that the patients are accompanied by an escort to their new facility for proper handing over. And these measures have significantly improved the efficiency and the safety of our patients on transfer. So our outcomes, I'm pleased to report that this initiative in mortality and the length of stay for patients, along with improvement in patient care, including closer monitoring and enhanced privacy. So our efforts have also been recognized by the community with a positive feedback reflected especially in cleanliness, that is as reported in our community scorecard. So for the bed occupancy in this facility, you can see in 2022, we usually had an average of 120% bed occupancy. But after the policy, no bed sharing policy, in Nyeri County Referral alone, we have about 90% in average. It ranges between 80 to 100. Here are covering teams. For instance, if you look at other level 4, what they reported in August 2023 is that if you want to know how many beds they have and you need to refer patient there, downward referral, you can see in female ward, they had 5 beds out of 18, which were empty. In maternity, they had 11 empty out of the 18. Mount Kenya, for instance, in male ward, they had 0 that day. For Karatina, male ward, they also had 0 beds available for both male surgical and male medical. And the same for County Referral Hospital. In maternity, they had a 0 bed that day for maternity cases. And also male surgical, 0 bed, to mean if they had any admissions, they would make a decision as to where to refer to do the down referral, especially for those patients who are feeling well in the ward. For those who require, say, consultants care, there is also the roving of various consultants, including the family doctor. And here are challenges. Our journey has not been without challenges, and we have faced the issues with inadequate coordination structures because we don't have patient safety focal persons in our health facilities. We just have one at the county level, and this is because the patient safety is domiciled in various committees at the facility level, that is in IPC, EMS, OSH, and MTC, and also the quality improvement teams. Then we also have, we lack budget. We have budget constraints, and these challenges actually highlight areas where we must focus our efforts to sustain and further improve our patient safety. We have also experienced patient deteriorating after downward referral, necessitating an upward referral. Then the health management system not integrated across all the levels of the facilities, but we are working towards that. Then there is also the suboptimal utilization of MOH 287 in reporting patient safety incidences. And this is somehow related to the fear of being victimized by the healthcare workers, fear of being victimized after they report. We are working on that too. So the lessons learned from our experiences, we have learned valuable lessons, leadership being crucial at all levels of healthcare delivery. We have also seen the importance of using existing structures and opportunities, coordinating services across healthcare facilities, generating local data to track progress, and starting small with focal persons or champions and building steps, step by step, have proven effective in driving sustainable change. So Nyeri County activities for the upcoming World Patient Safety Day, which is next Tuesday. We have daily patient education sessions, and we have included patient safety in our new staff's inductions. There are some inductions going on for new staffs. We started this week on Tuesday for all the facilities who have active Facebook pages. Then signing of whiteboard patient safety pledges across the facilities. This is another way of bringing awareness among our health facility workers, healthcare workers. Then we planned for maternity open day and a patient safety just around town in the relatively new Nyeri Town Health Center, which was done on 10th September 2024, and we interacted with our clients. Then for the ongoing ASK show, we have a stand which we share with AMS. And today we have the KNH-UON webinar on patient safety, where I presume a good number of healthcare workers in the county are in. And on Friday, we have the Moi Kibaki Hospital Patient Safety Symposium, and we welcome you all. So this is the team in the Nyeri Referral Hospital, where we have Benson Gary, the medical superintendent, AMS focal person, Sarah Kibira, our nursing manager there, who happens to be Peter Kimengi, the commodity nurse, IPC focal person Mugambi, the rest, and I at the county level being the county patient safety focal person. So thank you. And back to you, Dr. Karundu.
Okay, thank you very much, Boniface, for sharing that wonderful story of what you're doing in Nyeri County. So we've gotten a glimpse of what's happening at the national level. We've also had what is happening at the county level. And I think my first question will be to Boniface. Please remember to put your questions in the Q&A section. Apologies, the chat is disabled. I've just been informed that the chat section is disabled. Apologies for anyone who's trying to access that part. Kindly put your questions, your comments on the Q&A section. And congratulations, Nyeri County, for the efforts. And I like what you've said, start small and then build on it step by step. So there's a very interesting question that I've seen from Beatrice about the bed sharing. I think the bed sharing has really stimulated a lot of energy and appreciation for what the county is doing. So Boniface, there's a question about bed sharing. Does this policy apply to newborn in Nyeri County?
Yes, repeat the question, Dr. Karundu, please.
There's a question from Beatrice, and she's asking, does the bed
Yes.
sharing policy apply to newborns in the court?
Well, yes, we are supposed to do it in the first few years of implementing the no sharing bed policy. We didn't have it because for the newborns, we only had a good functioning NBU in Nyeri Referral Hospital. And now with the upcoming, we have a new NBU at Karatina, therefore no sharing. And the other one, which is in progress, we shall have another one by the end of this year in Mukurweini, to mean we shall not be having bed sharing, including in NBU.
Awesome. Thank you very much, and thank you for that response. And with this policy, and I like what you've said as one of the challenges, that once you do the downward referral, once in a while you'll experience deterioration of patients. And so my question is on health worker availability, experience, and skills. So in these facilities where you're planning to open up the newborn units, do you have trained personnel who can be able to support that? And what are the county efforts towards boosting the personnel who are already there in terms of training and capacity building?
Yes, thank you for that question. Every time we open up a new unit, two objectives are put in place. One, the physical structure, and number two, the capacity building. One, the capacity building usually goes on as the physical structure goes up. Once we open up, we have the capacity build staffs will open up that facility. And to mean, if we refer there, we have no problems with issues that patients are either mismanaged. And we learned that with the new Nyeri Town Health Center, which is a new, relatively new maternity. At the same time, within our newborn unit in Karatina, the staffs there were released to Nairobi, I think, in Jetrun. They got capacity built, and by the time the facility was to be opened, we had enough staffs to also teach the rest who will be coming in on OJT.
Thank you very much.
Dr. Karon?
Yes, thank you very much, and thank you for that response. In the Q&A, please kindly let us know if your county is also doing a no bed policy. If they have a no bed sharing policy, kindly let us know which county you come from and the county, so that we appreciate this. There's also the question you've already answered. There's a question you've already answered from an anonymous attendee. My next question will be to Dr. Irungu. Dr. Irungu, one of the challenges that have been mentioned from Nyeri County is the suboptimal utilization of the incident reporting tool, the MOH287. And you also mentioned it as part of the challenges that you're experiencing at the national level. What are some of the things that you've put in place to ensure that you demystify the tool and people are ready and feel free to be able to respond to it? And maybe you could just project, if you have the tool on soft copy, maybe you could project it so that everybody in this forum can be able to appreciate how it looks like and where they can access it.
Yeah, thank you. Thank you so much, Dr. Kalondu. I don't know if I'll be able to access the tool immediately, but I think as we proceed, I'll be able to pull it out.
Okay.
Yes, there have been a very, very big challenge in terms of reporting on patient safety incidents. At a national level, we've not rolled out patient safety incident reporting on a global scale. We've been piloting in 4 counties. And when we look at the results from the end, the KHIS end, it's very minimal. And the biggest reason why healthcare workers would report on patient incidents is the issue of the blame that may follow. And remember, one of the key concepts in patient safety is a no blame culture. So what we're trying to do now as we roll out patient safety work, remember, we know there has been a lot going on around patient safety, but in a very siloed manner. But we purpose as a ministry and as a unit to roll out a patient safety work. One of the areas that we want to focus on is advocating for the no blame culture. And the no blame culture clearly states that most of the errors that may happen to a patient may not necessarily be attributable to the health worker. And I usually give a very good example. A medical officer performing 10 cesarean sections at night, does CS1 to CS8, may make an error when doing cesarean section 9 because of fatigue. So, and remember, quality improvement says you focus on systems, not individual. That one has not been well taken up. So there's still that aspect of blaming the healthcare worker, and that has really reduced or affected the reporting rates of patient safety incidents. So yes, one of the initiatives is to promote the no blame culture, and this will start from the leadership, because I know I fear my leader, I fear my medical superintendent, I fear my county director of health if I make an error. But the moment if they come to learn of what we call the no blame culture, then we might get more reporting of patient safety incidents, and out of this, you'll be able to come up with measures to mitigate. Thank you.
Okay, thank you very much. And I'm seeing a question from Elizabeth on the same about blame culture, and I believe you've touched a bit on it. And so I think it's our responsibility, all of us, to ensure that we provide a safe space for each other to learn. And we are advocating for a learning culture in our institutions, in our facilities, and even the leaders who are in this meeting, that you advocate for a learning culture, a no blame culture, and a just culture. And we are also helping to establish structures in your facility that everybody can appreciate and understand. This is how we've standardized our care in this facility A, the way we can see Nyeri has standardized care in some areas. And there's a very clear guideline of what we do and how we do things. And that reduces the risk of being blamed. Back to the question about being blamed. And Boniface, this was a question from Beatrice about how your customers take this down referral and what happens when the condition worsens. Have you ever been blamed as a county or as a facility or even as a doctor? The personnel who transferred the patient, have they ever received any blame from the family?
Yes, what we do expectation management of the patient. Every time patient has have to be transferred out, they are actually counseled on it by the social workers and the healthcare workers who are under their care. And not every time we get good or pleasant feedback from the patient themselves, but for those who understand, they would rather go to the other facilities rather than share a bed. But still, we still don't lack those a few complaints here and there of a patient being transferred and not getting maybe the kind of comfort one would get from maybe the hometown one would prefer to be admitted in. But then we are still managing.
Okay. And I like what you said about managing expectations. And it's something that you're proactively doing using the teams that you have, the different healthcare professionals that you have in your resources. There's something you mentioned earlier on, Dr. Irungu, during your presentation as part of the success number 5, health worker education. And you talked about a virtual academy where you've created some modules and they are yet to be rolled out. I'm seeing a question from one of the participants asking where they can get this training. Where can they get training for patient safety, especially for communities that or counties that they feel they are challenged by patient safety? How can they get this training as they wait for this virtual academy to be rolled out? And maybe you can expound a bit more on the virtual academy. How can people join it? When is it likely to be rolled out? Is it free for all healthcare providers or is it for a particular group? And is there any cost?
Thank you. Yeah, thank you so much, Dr. Kalondu. Let me start with the last question. Yeah, the MOH Virtual Academy is an open learning platform. And basically all programs within the ministry are allowed to input their training materials. into that academy. You just need to log in and learn. As a unit, remember we have 3 programs. We have IPC, we have AMR, and we have patient safety. So we've just in the final stages of rolling out. But what is pending? Number 1, we want certification. So we want to incorporate certification into the training package. That's very, very critical. And number 2, we also want to incorporate CPD points within the running platform. So those are the few handles we are awaiting to cross over. Then we'll just roll it out. And the same way we've communicated on this, we'll share. The beauty now, social media, once it's open, trust me, you'll know that is now open for learning. So we also identifying managers, site managers, because there might be a lot of interactive sessions, Q&As. We also finalizing identification of specific site managers for the various training programs. So we hope that by the end of the year, they should be up and running, and everyone, and we can learn beyond patient safety. We'll have IPC material, we have AMR material, and there are more from other programs. And it will be accessible on the MOH website, that is the health.go.ke. Actually, even if you log in there, you'll see it, but you will not be able to access the material as we plan to finalize. I think there was another question. Yeah, I think I've answered the 2 questions, Dr. Karon, unless I missed one.
Thank you very much. And I hope the participant who asked that question has gotten their response, and they'll be able to log in and access what is already there as we wait for new material to be uploaded. And also, if there are any free resources that you know that have any training resources, kindly share on the chat so that anybody who's interested can be able to join and learn. Boniface, back to you. There's a question about pharmacovigilance reporting. This is from Joseph Chebon, and he's asking about pharmacovigilance and immovigilance reporting. Do you have any county tools for obtaining data? And do you share your reports with PPB or any other body that requires these reports?
Yes, Dr. Rhoda, thank you, Joseph. In the county, the tools that we have, they are not county tools, they are the national tools that we use, and some are digital. We have the FE reporting form, which is white. Then we have the medical device diagnostic incidence form, it's green nationally. And then we have the medication error reporting form, a blue form, and a pink form, which is a quality defects reporting form. They are all reported digitally, and I believe the PPB, they get these reports. Thank you, Karondo.
Thank you. And still on the issue of reports and what we measure, there was a question from anonymous attendee about what other quality parameters are you monitoring besides mortality rates? Maybe you could just say something about that.
Bad infections surveillance, specifically the surgical site infection in 5 major hospitals, that is level 4 and the level 5, including our level 6 KNH Odaya, and also 2 of our faith-based organizations. And apart from that, the other quality measure, apart from SSI, we also have the hand hygiene audits, and they are reported in the KHIS. We also have the isolates in our labs that are reported depending on the season, and also the numbers, how they are growing, and from our inpatients, that is. And then the other part of quality that is measured as okay, I got a thought block, but that I'm getting it off head. We have about six areas that we do measure our quality, but the ones that are specific is the SSI. We have the counties for the Nyeri County Referral Hospital. We are also trying the CLABSI, but we're using stolen tools, sorry. And then the rest of the isolates in the labs and what have you.
Maybe they're not stolen, maybe they're borrowed. Where did you borrow the tools? And is it something that people can also borrow if there are resources that people can
Yes.
start? We learn from each other, and as you
Yes, we
said, you
borrowed.
start small. So if there's any county person listening who would want to start, how can they start? Where
Well,
can they
what we
borrow these
did is,
tools?
yes, what we did is that we borrowed from KNH through KNH Odaya. They also started small. We started together and we are working together with them. Unfortunately, we just use the data locally. We don't report it on KHIS. Therefore, if you need the tools, liaise with any KNH branch. If the other branches in other counties, I don't know, but we have one in Nyeri where we got the tools for the HAI surveillance. But for the SHI surveillance, it had started a way long ago. We have the tools that we are using that the national team shared with us, and we actually report it on KHIS.
Thank you very much. Dr. Irungu, you talked about the national policy on patient safety, health worker safety, and quality of care. And there's a question from an anonymous attendee asking about this policy. Where can people access this policy? And how can they start implementing it in their counties, in their facilities, in their hospitals?
Thank you. The MOH website, that's the health.go.ke. It has a tab on guidelines and documents. So our policies are within there. So we just need to log in to the MOH website and you can be able to download the policy. Because nowadays we are trying really to go digital. I know issues around printing becomes a challenge, but the tools are available. In terms of implementing, you just emulate what Nyeri did or what Nyeri have done. It's so difficult to implement everything, but you can identify a low-hanging fruit or a low that you can be able to implement with a list of resources, and you start. The moment you start, then other things basically just follow. So there's no starting point. You just need to be able to identify a key area within your facility that you want to improve, then guided by the national policy, as well as the Global Patient Safety Action Plan, which is again available online. You can start off something and move on. Thank you.
Okay. Still on the issue of starting, is there any support that the faith-based organizations, the private facilities, or any county facility that is represented here can reach out to? And who do they reach out to? And what kind of support can they get, can they expect to get from you and your team?
I think the first thing is to, if you tell me, I want you to support me, I'll ask you, support you on what? So I think the first thing is to identify where is the gap. Because if you look at patient safety, it is a very broad aspect. We have issues of IPC, for example. Maybe there's a gap on hand hygiene. We have hand hygiene guidances. Maybe the issue is on rational use of antimicrobials. We have a lot of information and technical support. So I think the first thing is to identify the gap. Then the discussion around what support comes, then it will be very easy. But at this point, it's so hard to say that you'll get support from this partner or this person. Because like the various partners, we have partners supporting IPC, we have a partner supporting AMR, we have partners supporting safe care, we have partners supporting this communication. So it's a very broad forest, which it's so difficult to like specifically answer that question. But if you would be specific and say, we want to improve on this, then it is very easy to guide. But as a unit, that's why we are here. You can always write to us. I think I'll put I'll put our email on an email on the chat box, so that we can even start discussion on how to support activities. It may not be necessarily monetary, but trust me, even the idea of how to begin and start would also come in as a good support. And I always tell counties and other people, start something. When you start something, it's easier even to direct a partner when there's an initiative already put in place. Thank you.
Thank you very much for that response. Speaking of partners, Boniface, there's a question from Felistas about collaborations with the private hospitals around you or partnerships with the private hospitals around you, either in the no bed sharing policy that you have at the county level or in any other activities that you have. Of course, in your World Patient Safety Day activities for this year, you've expounded your partnerships with the different stakeholders. But is there any other collaboration or partnerships that you have with the other players apart from with the private hospitals and any other partners that you have in Nyeri County?
Yes, we have had a partnership. We have the Moi Kibaki, as I said, the KNH Odhaya, who we partner when we have activities. We also have the faith-based organization like the Tumutumu and Mathari. They have radio stations where we also use their radio stations for free to also communicate our messages to our communities. And the other collaborations is we have a few partners here and there who are local partners, like we call it Mukurweini Daily, who support IPC, but at Mukurweini Hospital. They support a few activities that are identified in their work plans. Working with the private hospitals, I can see there's a question from Felista. It has been hard because most of the time we've had turnovers. The turnovers are the main challenge in our private hospitals. Every year we train them, and in less than 1 year, they have left for greener pastures. Therefore, we have to restart again. Therefore, we are doing it again and again and over again. Maybe not until when they get to this level, but we have about 2 facilities which are private hospitals, which are actually trying to keep their staffs.
Thank you. And I like that you've talked about high turnover rates, which is something that's plaguing the healthcare sector, both public and private. And there's a question from Joseph Chebon about the outsourced cleaning services, and that might be one area where we have very high turnover rates. So whenever you get outsourced cleaning services, you talked about outsourced cleaning services and security.
Yes.
Do you
Yes.
train them in IPC, and how do you take care of IPC at that level?
I think we were fortunate when we started this outsourcing. The staffs whom we used to call the casuals, majority were hired by these outsourced companies, and most of them were trained on IPC, that is on housekeeping. The new ones who come in, there is a policy in every hospital where they are trained for a whole day as an induction on IPC and also the patient safety through the IPC focal persons at the facility. To me, nobody starts working without knowing the context that they are working in the facilities, in the healthcare facilities, more also about infection prevention and control.
Good, thank you. Thank you very much. There's a comment from Bernard, and it's talking about the bed sharing, the sharing of beds. And I think this is a big problem across public sector. And we are happy to hear Nyeri County and their story about the no bed sharing policy, and that they're trying to roll it out in all their facilities. It is a problem that is at the referral level all the way and trickles down all through all levels of healthcare system. Dr. Irungu, do you foresee a future where, maybe in the near future, as part of the patient safety champions are in this group, that we will have no bed sharing at all levels, at all counties, all national level, and what will that take?
That's a tough question, and I think I'll just feedback from my personal view. It's possible. I think Nyeri is no different from other counties. Nyeri does not have a separate kind of health workers. I think it's a policy issue. To me, it's a policy issue, and Whereas where the leadership appreciates the value of an intervention, then it becomes so easy to implement. So in my personal view, I think all other counties should benchmark with what is happening in Nyeri because it's doable. Because this tired system exists in all counties and it can work. So yes, I cannot say when, but I think there's a need for a lot of advocacy and information, and it can happen.
Thank you very much, and thank you for that response. And yes, it can happen. So Bernard, I hope in the near future, you will be able to hear more success stories, and you'll all be able to hear more success stories of counties, facilities, including KNH, having an OBED sharing policy. We look forward to that day. I'm seeing a few hands raised as we wind up. Maybe we could have one participant or two who raised their hands to say something. Nelson, if you're available, maybe you could allow two participants to say something, the ones who raised their hands. For Nelson to facilitate that part. Dr. Irungu, when we talk about the Global Patient Safety Action Plan, I mean, there's quite a lot that you've talked about Kenya's success story. And we are starting to envision what this success looks like at the national level. And we've also hinted on how we can trickle it down to the county level, to the facility level. How can these facilities that want to start monitor their progress with regards to the Global Patient Safety Action Plan? And where do they report their successes to? How do they get in touch? Of course, we're waiting for your email address, but how do they get in touch so that they can report to you their successes, whether big, small, every step that they take, and you can be able to consolidate all these efforts, and we're able to appreciate what every county, every facility is doing. And also just to ask, is there a network for the focal persons at the county level where they meet with the ministry teams to be able to also bring in their success stories and lessons and challenges to that forum? And how can they join? If this platform exists, how can the county focal persons join?
Thank you. Thank you so much, Dr. Kalondu. Let me admit that unlike IPC, unlike AMR, at a national level, we have not been able to actually operationalize patient safety initiatives. But through the support of the Global Patient Safety Collaborative, which has actually been supporting quite a lot of our work, we've scheduled and we've had approvals for a few activities. And key among them will be leadership sensitization. And we want to bring in, even if it's a set of pilot counties or a number of counties where we can start work, the first thing is an advocacy engagement with the key leadership from those counties, because there'll be no point of starting something that will not get a buy-in. So that's one area. Number two, we have also gotten support to train on patient safety, starting just the same way we started with IPC. We start with a set of national TOTs, whom we will assign to various counties to also cascade the training on patient safety. Then the other area that we are also looking upon being supported is having a more streamlined patient safety incident reporting system. Remember what I said is just we did a pilot with very few indicators just to see if it can work. But before even we come up with that system, we needed to have built that capacity to kill that so that health workers are free to be able to report. So those are a few what I may call foundational interventions we want to put in place before we can now actually say we are ready now to start reporting. But even now, trust me, even if I send you the tool, because we have a tool, although not digital, we are trying to digitize it, we'll still have a very positive of information coming in. So we are starting with the county MOH leadership, then we do county leadership, then we want now to sensitize trainers or to train trainers from counties so that they can actually now cascade that. Then after that, I think the next year support, we also now want to be able to establish the patient safety teams. But remember, we realize it's so difficult to have an IPC team, an AMS team, a patient safety team. So we want to have a discussion on how can we, all these teams that focus on quality of care, be supported to be able to implement the interventions. After that, now we can start talking about being able to report. I think for me, laying the best foundation is the most critical intervention that we need to put at this point. And luckily, we've been able to get support for that. And we are just, actually today is when I just got the letter of approval. So it's something that is coming and we'll get there. Thank you.
Okay, thank you very much. Boniface, there's a very good question that from anonymous attendee was, is your facility accredited by any local or international body?
Well, we don't have any international accreditation apart from now the labs, but we are registered with the national, that is the KMPDC, and actually all my facilities, the 130 facilities, only 4 which are not registered, and we noted after we were registering them on SHA, but all of them are registered with KMPDC, including their labs, because it's a requirement to register a laboratory and also license the pharmacy.
Very good. Yes, there's a comment about involving community healthcare promoters. Thank you very much for that. Maybe Boniface, have you involved the community healthcare promoters in Nyeri County in any of the initiatives, considering they are more likely to be your eyes at the community level?
Yes, come again, Dr. Rhoda.
Have we, in Nyeri County, have you involved or incorporated the community healthcare promoters in any of your IPC, patient safety, quality improvement initiatives, considering they are most likely to be your eyes at that level, at the community level? Have you incorporated them?
That started in 2023. That is last year, where we have the community focal person organizing per CU, that is the community unit. We have community projects under the CUs, that is the community units, where we have projects, health projects that they are undertaking at the quality, we are calling them community quality improvement projects, which they are undertaken. And they competed last year under the support of one of the, we call them they are the Catholic Brothers. And through this competition, we were able now to loop in more community units. We have about 1,200 plus community units, and the ones which are participating, and they are over, I think they're over 400. And the best thing is that they are all over the county, in all the sub-counties. We have taught them about the basic IPC. We've taught them about the AMS. And we had also to take out the drugs that were, the antibiotics that were in their kits, and they understood. And then we had now to train them on quality improvement projects at the community level. And this is continuing under the support of, I think, AMREF. Yes, thank you, Dr. Rhoda, back to you.
Okay. Thank you very much. And thank you for incorporating them. Henry Jaggi says, thank you for the presentation, and thumbs up to the entire Nyeri County IPC and patient safety and quality improvement teams. Under the able guidance of Boniface Macharia, I can attest to this unwavering effort. So good job, Boniface, together with your team.
Thank you.
Yes, we were able to appreciate that you have a multidisciplinary team, which is very, very encouraging.
Thank you.
Yes, there's also another question on the bed sharing of beds. Maybe that's something we hope as we come back again for more sessions, we'll be able to report success stories. And I'm seeing Felista is saying that Machakos County also has a similar policy of no bed sharing. So we continue starting small, step by step, county by county, facility by facility, and very soon it will be a widespread agenda that in Kenya, our patients don't share beds. The final question as we come to the end of this session is about data. Dr. Irungu, there was a question from an anonymous attendee about ensuring patient safety and information in the age of digital tech, especially artificial intelligence. And what are some of the supporting structures that exist to safeguard this?
Thank you. As I said, the piloting we've done is linked to the Kenya Health Information System. And for those who are keen on the Kenya Health Information System, it barely picks up key patient identifiers, like names. So mostly it's just on the key indicators, like the outcome of the process, which now guide on intervention. So the patient data is safe, but of course we say at the local level, at the facility level, you are able to extract more detailed information. For example, if you need maybe to intervene. So the data is safe. We are keen on the Data Protection Act. And so far, I cannot see there has been any impact resulting from the current trend on AI. But we watch and wait. But for now, the data is safe because we don't pick any identifiers, patient identifiers. Thank you.
Okay, thank you very much. I think we've had challenges accessing the microphone for some of the participants who raised their hands, and we hope in the next forum, probably we will be able to have that availed. Thank you very much, everybody, for logging into this session. We appreciate that you've stayed on through with us, that you've listened, you've participated, you've made it more interactive and engaging. You've asked your questions, you've expressed your concerns, and you've basically made us aware that there's some areas that there's a lot of effort that needs to put in. There are quite a number of participants who say this is the first time they're hearing about this. And we look forward to a time where all of us will be talking about the Global Patient Safety Action Plan, and we will all be implementing something small in our communities, in our facilities, in our counties, in our institutions. We come to the end of this forum, and we want to thank the KNH research team for facilitating us and for providing this platform. We also want to thank all the partners who are represented here for providing the support and for guiding us during this World Patient Safety Day series. We would love to pass on our gratitude to the ministry team that has been spearheading this, and they've been guiding us in this. And we thank you so much for all the efforts that you've put in holding our hands when it comes to IPC, AMR, AMS. We look forward to a lot more hand-holding when it comes to patient safety, and very soon, probably in the next near future, we will be reporting positive results and everybody will be speaking the same language. We'd like to invite you to our next forum, which will be next week on Tuesday. We will have another session on during the World Patient Safety Day series on Tuesday next week, 17th, and on Thursday, 19th. Kindly join us, and we look forward to more interactions with you. For those with questions and concerns about their CPD points, we hope that this will be addressed soon. We will forward your feedback and your concerns to the KNH research team, and to be able to see how we can get this webinars on the PPB portal. And for those who have not received their points, I'm saying there's somebody who needs it for their nursing council exam. Kindly reach out to KNH research team on email. The email that sent you the link for this webinar, use the same email to raise this now that we can see that you really need this for your exam. Thank you very much, and have a good afternoon. Thank you, Dr. Irungu. Thank you, Boniface. We look forward to hearing more from you next time again. Thank you. Bye.
Thank you so much.